Thank you all for joining and greetings wherever you are. Good morning, good afternoon. We're just going to give 2 more minutes to have some more participant log in and then we're going to get started. All right, we're going to get started. So first, welcome to you all to this webinar 4 of 5 scheduled webinar series. It is wonderful to have you join us on this Niche Choices VPOP webinar series. And I just want to let you know, for those who may not have had a chance to attend webinar 3, 201, please, there is a webinar recording that is going to be shared with you, the link on the chat. Listen to it. For me, for example, I missed webinar 3 and it was wonderful to log in and listen to webinar 3 session. So the recording is an excellent resource that you can look at, even if you missed one of the webinar session or many, and you can share this with your colleagues. So to welcome you all, and first, thank you to the partners who have come together to put this webinar series that has been so far excellent. And as an introduction, my name is Benjamin Kagina. I am the director of the NITAC Support Hub, which is a project based at the University of Cape Town in South Africa. We've had 3 webinar series in the past. We started by looking at the overview of national vaccine introduction and talking about the differences between prioritization and optimization, and then went to webinar 2 where we looked at the introduction to the tool, which is the NVI-PST. And then the last webinar, which was webinar 3, we looked at defining the criteria for the tool that you use as a NITAC together with your partners at a country level to define what need to be considered to help you in prioritization of the vaccine introduction. And what was interesting in the last webinar was that there are so many criteria that you need to look at. To be precise, 71, and these criteria were defined looking at quite a lot of literature related to what factors should be considered when it comes to vaccine introduction. And practically, it's impossible to use all those criteria. So webinar 3 focused on narrowing down on those 71 criteria to manageable level. And then certain groups of experts sat at global, regional, and national level, looking at what criteria should be considered as essential and that must have for any country. And, some of the criteria that were discussed in the last webinar includes the importance of disease burden and vaccine characteristics, and then looking at the issue of external factors such as availability of the vaccines and also the economics of the decision that need to be made on prioritization, and also looking at the programmatic factors such as the feasibility and also acceptability and also the logistics of introducing a new vaccine. So that has been excellent. And again, Salim, if you could please share with the participant the links to the previous recordings, I would highly encourage you to look at those recordings, listen to them if you haven't been part of it. So for today's webinar series, which is webinar 4 out of 5, we're going to go into the national vaccines introduction, prioritization, and sequencing tool, looking at the application. Right, and we've got an excellent lineup of presenters. I know them, all of them. And we're going to get started with Edina, who is going to look at the health system factors in the context of what enables, what are the barriers that relate to health system. And then we're going to have Johanna speak to us on the specifics of the prioritization and looking at the scenarios. And then we're also going to have Solomon. If you could please share with us, Ramonde or Salim, the program so that people can just familiarize themselves with today's webinar series program. So quickly, I'm just going to request all the speakers for today to just introduce themselves briefly, 1 minute before you get started with your talk. And just to mention that we do not have any interpretation for today. It's an English session only. Tomorrow, this similar time, we're going to have a French. And then at the bottom of your Zoom window, you have Q&A. Please post any questions, comment, or suggestion to us on Q&A. And together, we are going to address the questions, comment that you post. And so this is the schedule for today's webinar. We're going to have Edina talk about health system, Johanna talk about prioritization, candidate vaccines, and the scenario, importance, and feasibility. We're going to have Solomon talking about sequencing scenarios, incorporating EPI. And then we're going to have Akbar talking about Iran's experience. And then we're going to have a moderated interactive discussion. So you don't have to wait for the moderated interactive discussion to share your question or comment. Please use the Q&A. And with those remarks, I'm just going to invite Dina to take us through the first talk of today's webinar. Over to you, Dina, and thank you very much and feel very welcome. Thank you.
Thank you very much, Ben. I'm just going to take some time to share my screen and then probably start introducing myself. So hopefully it's showing on your side. So my name is Adina Ponce da Costa, and I serve as one of the research officers and evidence-informed decision-making specialists with the NITAC Support Hub here at the University of Cape Town. And it's quite a pleasure for me to be presenting this particular talk on behalf of myself and my colleague, Bronte Davis. So over the next couple of minutes, the main objective of this particular talk is to make us acutely aware of how health systems determinants influence immunization programs and how we can leverage those very same determinants to strengthen NITAG recommendations, including decision-making around vaccine prioritization. So let me just get rid of the banner that's showing on my side here. There we go. So just to start off by asking, why do we need to contextualize vaccine decision-making and vaccine implementation within health systems realities? First of all, we need to understand that health systems basically constitute the structural environment within which vaccine policies are formulated and health services are delivered. So any changes that occur within the health system can have a knock-on effect on immunization programs. For instance, introducing a new vaccine may increase health workforce workload. Additionally, new vaccine introductions may face delays due to bottlenecks, not necessarily within the EPI, but across the broader health system. when we see funding cuts occurring towards specific health programs or across various health services, these could have significant implications for the capacity of the health system to deliver immunization programs. Health systems governance is also a very important issue. This is because leadership quality and accountability are strong predictors. Time and time again, it's been shown to be strong predictors of vaccine coverage. So in instances where we have low levels of political commitment or political will, or where we have weak policies that are not contextualized within local realities, these again could have significant implications for the success of delivering immunization programs and achieving high vaccine coverage or uptake. Lastly, NITAG recommendations may fail when systems constraints are not adequately appreciated during the process of developing vaccine recommendations or policies. So essentially, immunization performance is shaped by the broader health system, and health system enablers and barriers affect NITAG recommendations. So NITAGs must understand systems constraints in order to make credible, actionable, and locally relevant recommendations. Now, it's important for me to also emphasize upfront that health systems are complex systems. And this complexity often means that any challenges that occur within the health system it's important that we see the health system from various vantage points. So we need to have various individuals working together who are able to collaborate and have a shared understanding of the complex issues and develop complex solutions to the challenges that we face. And that is what you see in the image to your right. And this is as opposed to seeing certain systemic issues from a single vantage point, so-called vertical approaches, which can lead to siloed visions of the challenges that we see within the health system, as you will see towards the left-hand side of the image. So here we go. There are various health systems frameworks. The one you're seeing here is the WHO Health Systems Framework, and it comprises of specific inputs, also known as health systems building blocks, as well as outcomes or outputs. So these inputs include service delivery, health workforce, information systems, medical products, which include, in our case, vaccines, and also cold chain and logistics systems. It also includes sustainable financing and also leadership and governance. And then the overall outcomes of the health system is that we want to achieve improved health for the populations that we serve. We also want to deliver responsive health services and specifically immunization programs that address the express needs of the populations. We also want to ensure risk protection. Meaning that we want to make sure that populations do not suffer undue financial burden for the very simple purpose of having access to health services. And then lastly, we want to see improved efficiency across all health services. Now, health systems frameworks are very important for policymakers like NITAGs because they help them identify critical challenges within their local health system and then develop recommendations that help surmount those specific challenges. So, in addition to being complex, health systems are also dynamic systems. This basically means that the various building blocks are constantly interacting in order to achieve the health system outcomes that we actually want to see within our populations. So across between building blocks, we have multiple dynamic relationships. And for effective vaccine delivery, we need the interconnected parts to function together in order to be effective. Where we see challenges or gaps in one specific dimension, these can have repercussions for other building blocks within the health system. Whereas improvements in one building block cannot be achieved in other dimensions without strengthening the health system all across. So health systems strengthening is important in order to achieve equitable and sustained immunization programs. And this needs both technical and political knowledge and action. So we understand that immunization programs are embedded within the health systems. And so for immunization programs to function at optimal level, we need several determinants or several contributing factors. And this includes good governance and accountability. It also includes having reliable supply of vaccines. We need effective quality service delivery, including outreach and good service coverage. We need quality data for micro-planning. We need training for the health workforce because we need a capable health workforce to drive immunization programs. And more importantly, we also need sustainable financing mechanisms to cover operations and consumables. So there are several roadblocks that are facing immunization programs within our local systems, and these include poor cold chain maintenance, lack of infrastructure, low vaccine knowledge, or limited access to training for healthcare workers. We also have challenges in terms of availability of reliable coverage data to inform action. We have supply chain disruptions. We are seeing several funding cuts or shifts in global priorities, and then there's dwindling vaccine demand. But there's also those winding and often challenging factors that affect immunization programs. And in this case, we were referring to certain contextual challenges as well as looking at the relationships between the actors that are involved within the health system. So when we speak about the contextual issues, we're referring to those sociocultural beliefs that often lend themselves to negative vaccine perceptions, low vaccine demand or uptake or acceptance. We're also seeing rising conflicts that are contributing to displacement of populations, which makes it difficult for us to reach them, but are also decimating critical health systems infrastructure. And then there's zero dose populations, which is quite a topical issue now. And often we are challenged by trying to identify where they are in order to reach them with the life-saving vaccines that they actually need. And then in terms of health systems actors, when it comes to immunization programs, we're referring to all those individuals that are working across immunization services from the policy level, such as NITAGs, individuals that are working in the ministries of health, and the health systems end users themselves. And all these different actors have their own beliefs and behaviors and power structures that all contribute to some of that complexity that we touched on earlier. So in terms of health systems considerations for vaccine prioritization and introduction, what do we really need? What we need here are strong political commitment for vaccine introduction. We also need availability of sound policies that are grounded within local realities and contexts. We need reliable supply of vaccines, effective cold chain and logistics systems. We need effective and quality vaccine delivery services and models. We also need affordable vaccines that can be accessed through sustainable financing mechanisms. We need a capable health workforce to drive these immunization programs. We need sound, culturally appropriate, context-specific communication strategies that mobilize our communities to drive up demand generation. And we also need effective monitoring and continuous improvement of the vaccination program that is guided by sound and quality data. So what do NITAGs need or policymakers need in terms of applying health systems thinking during the policy development or formulation process? Well, they need to understand or have a better understanding of the strengths and weaknesses across their local health systems. They need to conduct health systems analysis to better understand the barriers and cross-cutting systemic issues that affect their local immunization programs. They need to identify where policies need reform and engage, broader stakeholders, including civil society and the communities that are served. They need to understand stakeholder perceptions and expectations because, as I mentioned, these often contribute to some of the complexities that we see within our health system. And then they need to give recommendations that are feasible and grounded within the local systems, all the while appreciating the complexities that exist. So, in summary, if you weren't convinced already, I hope that I've been able to convince you that careful health systems considerations is critical because these shape the success of vaccine decision-making processes as well as immunization programs. And so, with that, I will stop here. Thank you very much for your attention, and I'll hand over back to Ben.
Thank you so much, Adina, for that great talk, just to set the scene for us. So I'm going to hand over now to Joanna Heeman. Joanna, if you'd like to share your screen.
Thank you so much, Ramondo. Thank you so much, and good morning or good afternoon for some colleagues. My name is Joanna Feeman. I'm part of the WHO Immunization Vaccine Biologics Department in WHO headquarters in Geneva. I've been working on this approach to vaccine prioritization and optimization for the past 3 years, including the session that was presented at SAGE in March this year, and working in close collaboration as well with key partners. So it's my pleasure to join you today and to present for this fourth webinar the questions of, and I will use my second screen, so the questions of prioritization and coming back to the new vaccine introduction prioritization sequencing tool and focusing really on the second workshop and the next steps, which comes to prioritization and sequencing. You recall, for those who attended the previous webinar, that there was a discussion on how to select the criteria and the vaccines that would be presented and considered for prioritization and for sequencing. And so the purpose of the discussion today is really to focus on this second workshop, and that will then lead to the final recommendations on which vaccines to prioritize and then in what sequence. So as a reminder, and really just the overall expected output of this second workshop is to be able to prioritize between the candidate vaccines that will be reviewed and to produce sequencing scenarios. And we'll come back to the links with the presentation that Edina just gave on the importance of considering the context and the overall system and program in place when making such recommendations. So we'll look at what it means in terms of the reviewing the evidence, the ranking of the vaccines, and then how to go about the prioritization and the sequencing. And I'll try to highlight as well all of the different tools that are available in the NVI-PST so that to facilitate as well the process. I will stay very much focused on the guidance and the process. I'll try to give some brief example, but we will be looking forward to hearing from the experience in Iran and in Ethiopia to really bring some concrete aspects to this step and this important workshop. So, importance and feasibility. How do we go about ranking these vaccines? So you recall that in the third webinar, there was this presentation of the different criteria that should be selected, identified and agreed upon as essential to consider as part of the exercise. Those criteria are organized based on importance and then on feasibility. When referring to importance, it's really about the expected public health and societal value of introducing the vaccine. So why this vaccine matters for the country, and this refers to, for example, mortality or vaccine effectiveness, whereas the feasibility is really about how realistic and achievable is this introduction. And that can be very much about whether the vaccine is available, whether funding is available, what is the status of the cold chain, etc. When those criteria are reviewed, it's important to then be able to review them and to rank them. And so this slide really shows that the order is really to focus first on the importance and the criteria that are under this category of importance to reach a ranking, and then to go to the feasibility criteria, and again, one by one, to go step by step and do this ranking. So how? Essentially, it's a 3 steps approach. The first one will be to review the evidence criteria by criteria, and it's up to the Secretariat or the NITAG working group to present the summarized evidence, to present the consolidated data, and highlighting the sources, the assumptions, and any potential modeling. At the second step, the NITAG as a group will discuss the evidence and review what has been presented to then inform a vote on each of these criteria. And that will then be used to rank the vaccines so that, again, there can be a discussion on the different rankings of the criteria for each of the vaccine. If we look at an example, here is an example on the summary of evidence related to incidence, looking across different vaccines, so cholera, influenza, typhoid, MEN5, DTP booster, and EXA. And you can see on the right here the different comments as well that are really essential to capture on where is the data coming from, and to ensure that the process of presenting this evidence is also unbiased and as accurate as possible to inform the discussion of the NITAG. So this is an example of how the summary of evidence can be presented to the NITAG. And as a second step, there is this ranking on incidents that is then done by the NITAG. And you can see here that we've also color-coded NITAG core members' votes versus all attendees to inform the actual process. So again, essential to really build on the methodology to ensure the robustness of the process and to be able to present these recommendations. What this means is that once each of the criteria has been presented, reviewed, assessed, and that the NITAG has been able to vote, you have the overall view of the ranking for each of the vaccine and each of the criteria. That's placed on a matrix that then allows for prioritization. I really want to again highlight that the NVIPST and the tools available on the NITAG Resource Center include the tools that allow you to develop those visuals as well, and that can really facilitate the work of the Secretariat in presenting the information. So if we start here on the left, you can see that the first table at the top is focusing on the criteria for focusing on importance. So again, incidence, mortality, cost of the disease, etc. And that allows you across each of the vaccine to reach an average ranking with weighting that may be decided. Again, this was discussed in the previous workshop, but that gives you a score that can be applied across all of the vaccines. The bottom one focusing on the feasibility, such as the availability of funding, the availability of the vaccine, the cold chain, etc. And again, allows you to have a ranking of how feasible is it to introduce these vaccines. And then the ranks and the vaccines are placed on this feasibility versus importance chart. So that allows you to have a very clear visual of what is important and feasible versus what is less important and less feasible based on the votes and the ranking of the NITAG and the assessment that was done. This then allows to define priority levels based again on the rankings and based on the discussion, identifying in this case the high priority vaccine as hexavalent and rubella, the medium priority vaccines, which is a mix of the important but less feasible and less important, less feasible here, and then the low priority vaccines that are identified as cholera and typhoid. So this really shows the importance of not only the ranking, but also the discussion and the engagement with the NITAG on defining these priorities. So once the ranking has been done, becomes the important step of scenario and sequencing, and again, taking into account the EPI constraints and the uncertainties. And I think we've heard very clearly on the importance to take into consideration the program constraints, which are listed here as an indication of some of the considerations to take into account, but also the vaccine constraints. So I really want to agree and again echo the presentation that we heard from Edina on the importance to consider the broader health system and the opportunities related to new vaccine introduction versus actually just looking at only the importance criteria. The second part is also related to the vaccine constraints, which include the availability, so whether the production is adequate, but also the funding constraints and the overall perspective on the sustainability of the vaccine programs and the ability to ensure the continuity of the newly introduced vaccines. And then finally, again, just looking at the availability not only of the vaccine, but also on the ancillary supplies and the overall logistical constraints related to the introductions. I'm actually not going to go through examples around this because this will be very much covered in the presentation that we will hear from Iran and from Ethiopia. And I will therefore let Professor Salomon and Dr. Akbar present on their specific experience. So coming to the drafting scenarios, once the ranking has been done and the high priority vaccines, medium priority vaccines have been identified, and taking into account the programmatic constraints, the NITAG is then able to draft scenarios on what should be the sequencing of introduction. It's important, and our recommendation is really to draft at least 2 scenarios that take into account some of the uncertainties and the variables that are not in control of the NITAG. This could be, for example, in terms of the funding perspective. And the assumptions behind those scenarios should always be very clearly laid out. We also recommend to stay consistent, of course, with the vaccines that were identified as high priority versus medium or lower priority in the recommendation for the sequencing of introduction, and taking into account as well the program and the vaccine constraints. Being realistic is also important. I think one of the aspects of this prioritization exercise is also to manage expectation and to facilitate the planning and the coordination, possibly with manufacturers, possibly with funders and external partners. So it's really essential that the recommendations of the NITAGs are realistic. And so there's also a list of tips here that are listed on the right of the slides that you may want to consider. I think the ones I'd like to highlight is the opportunity to highlight when would be the earliest year of introduction for each vaccines, which is a good practice and the lessons that we've learned from the countries that have gone through this exercise. And again, take into consideration as well segmenting the introductions between the easy introduction versus more complex one, and how that might affect the scenario. So my last slide will be just to give an examples on what sequencing and this scenario may look like. And you can see here the result of an ITAG review that has identified in which order they would recommend to introduce future vaccine, starting with rubella vaccines, and then the second one being linked to meningitis. And I think the key message on this slide is that in the preferred or primary scenario, the country would start by introducing rubella, followed by MEN5, cholera, and then typhoid. And then the alternative scenario, which is very much linked to the availability of MEN5, is to actually introduce rubella first, then MEN-A, followed by cholera, and then instead of introducing typhoid, the NITAG recommended to prioritize the switch to MEN5. So this is one of the concrete examples of how those recommendations may serve the actual implementation of these introductions and the sequencing. So with this, again, this was very much focused on the guidance, on the availability of, the different steps and how to apply them. What are the good practices in presenting the evidence to facilitate the discussion and reaching consensus within the NITAG on which vaccines to prioritize and in which sequence. And with this, I'll hand over now back to Raimonda and to hear some of the concrete examples from Ethiopia and Iran on how those steps were applied. Thank you so much.
Thanks so much, Joanna. That was great. So as you can see, we're progressing through this gradually, just with the background, and then hopefully you have some questions that are coming up. Unfortunately, you're not able to access the Q&A, so please drop them in the chat meanwhile, so we can collect them. And without further ado, I'll now hand over to Prof. Solomon Memiri from the Ethiopian NITAG. Over to you, Prof. We can see your slides. Thank you.
Hi. Good morning and good afternoon. I'm Solomon. I'm a pediatrician and health economist, currently serving as chair of the Ethiopian NITAG. I'm also the director of the Center for Ethics and Prior Setting, which is based at Addis Ababa University. What I'll be talking about is the Ethiopian NITAG experience on new vaccine prioritization work that we have recently accomplished. I think it's visible, yes? Therefore, I start with the process that NITAG has undergone to prioritize vaccines. And this started with, key stakeholder alignment that included the NITAG chair and members, and also, the EPI unit as well. Therefore, this were, briefed on, the new tool, and they have agreed, to use this new tool in the Ethiopian context. After getting the stakeholder alignment, then an online session was conducted, which, introduced, on the new tool for the NITAG members and other vaccine stakeholders in Ethiopia. Then after, the online session, we did workshop 1, which was conducted an in-person session. And this was for adapting the framework of the new tool to the Ethiopian context. On this, NITAG members and other vaccine stakeholders were part of this exercise. And during this exercise, actually, NITAG and other members discussed and selected 6 vaccines and 13 criteria, including around 32 indicators. The 13 criteria were selected from the 71, which was identified by the choice team. Therefore, it's hard to consider all. Therefore, we only selected 13 out of the available 71 criteria. Then after, the initial workshop, data on the 6 vaccines for the 13 criteria and 32 indicators were collected from various sources and were analyzed. Afterwards, the findings were presented during the second workshop, which was conducted around March 4 to 6 in 2025. And in total, 24 participants, 8 of those participants were NITAG members. Because of other commitments, we couldn't get around 5 NITAG members to participate in this exercise. Finally, NITAG gave a recommendation after discussing, possible programmatic and financial constraints with EPI manager. These were, the envelope of vaccines that we chose from. And these are the 6 vaccines that NITAG chose for the prioritization exercise, which included meningococcal vaccine, which is a multivalent conjugate vaccine, measles rubella, hexavalent switch from Penta plus IPV, cholera vaccine introduction, and the other vaccines were typhoid and respiratory syncytial virus vaccine. These vaccines were, for this vaccine, we collected all the required data. Therefore, criteria and indicator selection, I have already said about among the 71, we chose 13, which we thought would be manageable and are critically relevant to the Ethiopian context. Therefore, among these 13 criteria, we also identified about 32 indicators. And we categorize these criteria as absolutely critical, essential, and important with different weights. And the highest weight was given for those identified as absolutely critical, which was 3. Essential was given a weight of 2 and important 1. And as Joanna has already said, some of the criteria assesses, importance of the vaccine within that specific context, while the others will assess whether it would be feasible to introduce that vaccine in that specific context. And we have used a time frame of 5 years. Therefore, these are, the criteria, and this table shows the importance criteria, and we have selected 8 important criteria that includes, the incidence of diseases, prevalence, mortality and lethality of the disease, contribution to goals, which may include global, regional, or national goals, effectiveness of the vaccine, duration of protection, serogroup coverage, existence and accessibility of satisfactory alternatives, where the criteria that were selected as important to show the importance of vaccine introduction within our context. As you can see in the classification, they were classified as is absolutely critical, essential, or important with different weights. On the right side, what you see is the indicators that has been selected for each of the criteria. This is another table which shows, the feasibility criteria, and this included risk at individual level, availability and sustainability of funding, market availability of the vaccines, and cold chain capacity, and the expected impact on human resources. And for each of these criteria, we identified, several indicators, as you can see on the right side of the table. We have used, different data sources to generate evidence around each of the criteria and indicators. And, on burden of diseases, we have used, a number of sources, including modeling estimates, finance and economics were, largely extracted from Gavi and UNICEF sources. And for others as well, we have used different sources for data synthesis. Therefore, after collecting all the data and after doing the analysis, in the second workshop, the evidence was presented on all the 6 vaccines and for each of the criteria and indicators. And for each criteria, once the evidence was presented, there was discussion among NITAG members and other stakeholders. And after discussion, they were allowed, to rank each vaccine based on the evidence presented. This was followed by summarizing and presenting the average rank for each vaccine. After summarizing and presenting the average rank, NITAG members discussed on that. And usually, which one should come first and second was, besides the numbers, it was done based on consensus additionally. This is the table after, doing the ranking for the importance criteria for each of the vaccines. Based on the importance criteria, hexavalent was ranked first, followed by rubella vaccine, which is, which would be administered as measles, rubella. You can see for each, importance criteria, the scores, the average scores that were given for each of the vaccines. The last on the right, the column shows the average ranking consolidating for the importance criteria. Therefore, hexavalent and rubella rank top, while cholera and typhoid ranked least based on the importance criteria in the Ethiopian context. This is the table presenting the feasibility criteria. As you can see, we have considered 5 criteria, and based on the feasibility assessment, still hexavalent rubella remained, the top ranking. But now the RSV ranked the least, which was somewhere in the middle in the importance criteria. And the main reason is, the lack of availability of, RSV vaccine within the market at large scale to satisfy the needs of big countries like Ethiopia. And there was no actual commitment from sources like Gavi for funding of RSV. That's why it ranked low on the feasibility criteria. Therefore, putting, both the importance and feasibility criteria, we will have, this combined ranking, and hexavalent and rubella ranked, first and second, while, cholera and typhoid ranked the list based on the combined ranking. And Joanna was talking about, this axis, the importance and the feasibility axis. If you lie on the right upper quadrant, then that vaccine would be, both important and feasible to introduce in that context. And we see that hexavalent and rubella were found to have, be both important and feasible to be introduced in the Ethiopian context, while cholera and typhoid seemed less important and less feasible for introduction in the Ethiopian setting. Meningitis and RSV were in between. Therefore, these were based on these charts. These were categorized as high priority, hexavalent and rubella, for possible introduction in 2026 to 2027. We ranked hexavalent first, followed by rubella, then as medium priority vaccines, MMCV and RSV. Then low priority cholera and typhoid. Actually, cholera vaccine is not new to the Ethiopian healthcare setting. We are using it, during outbreaks as preventive campaigns. Therefore, I think that would continue to be used. But here the consideration is that it will not be recommended for routine use in the Ethiopian context. Therefore, the other important things that we have considered is constraints and uncertainties for the immunization program. These were taken into account during our recommendation on which period to introduce and what to introduce in the Ethiopian setting. Therefore, among this, funding constraint was a thing that was considered. Therefore, you see that recent funding decreases from Gavi. Therefore, this uncertainty, what does it mean for new vaccine introduction, that was factored into our decision making. And co-financing for some of the vaccines is not yet clear. Therefore, that would have ramification on the decision that we have made. The other thing is, Ethiopia is introducing lots of vaccines. Some of them has been introduced recently. We, in 2025, introduced malaria, and we are introducing hepatitis birth dose. We are switching from 10 to 5 measles dose. And this will burden the health system. Therefore, on top of this, we have assessed whether it will be feasible to add more vaccines into the health system. The other thing is we are conducting periodic campaigns that also require it's a heavy burden on the health system. Therefore, what campaigns are planned and so on were discussed during our prioritization exercises. The other works that are ongoing or also are part of this discussion, like zero dose agenda, which is a bigger agenda in Ethiopia, where zero dose infancy is among the highest in the globe. Therefore, that's a critical issue. And structural capacity, operational capacity, and what would be our recommendation for the planned national immunization strategy, which is currently being developed, was part of the discussion. Therefore, we have also encountered some challenges during the prioritization exercise, and some of this relate to data gaps on disease burden. And for some of these conditions, we have only modeled estimates. The other thing is we didn't have locality wastage rate estimates for the Ethiopian setting. The other is estimate of the health workers' time for each candidate vaccine was not available, and this has been a challenge. And we didn't have data on public perception of diseases and vaccines, which has affected some of our decision making. Therefore, I think it's important that we should strengthen disease surveillance activities and the quality of routine reports, and improving also data accessibility. And in some instances, we need to generate evidence through research and so on. I think this would be a lesson for future such exercises. Therefore, what we think are as key takeaways are, we should be able to establish, strong linkages between technical recommendation from NITAG and the programmatic planning process. And in that regard, we have an ongoing discussion with the API team on possible integration of our recommendation in the upcoming national immunization strategy. The other thing is improving engagement of NITAG members. Some of the NITAG members didn't participate in this exercise because of other commitments, but we have to improve, and we need to have a strong secretariat where, they would be able to collect data and do the analysis for similar future exercises. And we recommend that, this is not the end. We should have similar exercises because, so many of the things are evolving. Vaccines are evolving, funding might vary, also contextual factors, and we should be able to, frequently do similar exercises. And, our exercise could be a valuable one to other NITAGs as, experience sharing. Thank you very much. And back to you, Ramonde.
Thank you so much, Professor Solomon. So I think we will agree that it's becoming more and more complex. We were going to just check if the Q&A box is working, but thank you. You've seeded one question. So I'm going to ask Akbar. Akbar, if you'd like to proceed with your perspective from Iran, appreciated. And I'll let you know as soon as we can see your slides.
Yes, thank you very much, Romanda, and I appreciate Nish for inviting me, and it's my great pleasure to share Iran's experience of conducting the tool and the framework of prioritization. Uh, if Can you see my slides?
We can see it, just not in
Yes.
presenter mode yet.
Yes.
Perfect. Thank you,
Yeah.
Akbar.
Thank you. My name is Akbar Futuhi. I am a professor of epidemiology at Tehran University of Medical Sciences and a NITAG member, not a NITAG chair of Iran. And I was a team lead of this project. Very quickly, I'm trying to share with you our experience with some focus on challenges and practical issues of conducting the tool. We began the project after taking part in a workshop in Tunisia. Joanna and her colleagues taught us how to conduct this process very smoothly. And after that, we tried to follow the process exactly the same we learned from Joanna and her colleagues. And we have done these steps an online session for arrangement. After that, we conducted an online survey to get some information from NITAG members and their understanding, very preliminary understanding of what they think of vaccines and prioritized vaccines and criteria in their mind. After that, we conducted workshop one. After that, we collected evidence for 70 criteria that we have chosen out of those 71 criteria. And for seven vaccine candidates, we collected those evidence. After that, we conducted workshop two, and what we did for briefing policymakers and convincing them. As you can see here, we first conducted an online survey, and we found out that the preference of NITAG members in terms of time frame is 5-year time frame for this process, and they have chosen 7 candidates out of 20 to 23 23 vaccines in the pool of vaccines, available vaccines for introduction in Iran. And so 7 vaccines have been chosen, and out of 71 possible criteria, we have chosen 17. Here you can see the results. We conducted an online survey or online voting during the process of conducting workshops. And a very important and practical issue during this process was that when we ranked, I mean, when NITAG members ranked the criteria, because of their backgrounds, usually from clinical background or academic background, it seems that they priorities were importance criteria. As Joanna described, we have 2 categories of criteria: feasibility criteria and importance criteria. And feasibility criteria are usually a big concern of MOH people, those who will implement the vaccination process, because they need to be able to conduct or introduce new vaccines. But NITAG members prefer and voted higher ranks to importance criteria. Because of that, we decided to have more criteria, and it was a burden for us to collect enough evidence for those 17 criteria. And the other challenge was that the process of conducting workshop 2 was difficult, because we needed to discuss about 17 criteria. For keeping the balance between for importance and feasibility, we skipped some higher ranked criteria that they were in the category of importance, to reach more feasibility criteria. Finally, we reached these 17 criteria, and we could reach 5 feasibility criteria to be able to produce that 4-quadrant graph that Joanna showed us. And like Dr. Solomon, we collected information. We decided about indicators for each criterion, and we collected evidence during a 2 or 3 months period. And we conducted the second workshop. And during the second workshop, NITAG members in fact, we presented all evidence for all 7 vaccines, and for each criterion, they voted and they ranked these, vaccines. And you can see the summary of ranking importance and ranking of feasibility criteria, and then we combined. Dr. Solomon showed us the weighting they used for those criteria, and we conducted two schemes of weighting, and the result didn't change, so it didn't matter for our case, at least. And finally, we mapped these 6 criteria. We decided to exclude one of those vaccines because of some issues that I will not go to details now. And finally, we graphed those rankings, feasibility criteria and importance criteria, and we could reach these 4-quadrant map. And then we discussed in the second day of workshop, we discussed how to categorize these six vaccines to three tiers: high priority vaccines, medium priority vaccines, and low priority vaccines. And so obviously we decided to exclude these low priority vaccines from the plan of introduction of new vaccines, and we discussed about constraints a lot. I mean, in the second day, we had a very heated discussion with MOH people and NITAG members, and finally, we developed these two scenarios, and we decided to introduce, for the first scenario, we decided to introduce these, I mean, for vaccines with this timeline, and we developed another scenario as an alternative to MOH authorities. Then a very important step was to introduce the results of this process to MOH people. We developed a policy brief document, something like this, like a policy brief, a 7-page document, Iran NITAX recommendation, with all sections about the background, the methodology we used, and finally the result and the final recommendation. We had meetings with the chair of CDC, Iran CDC, and the vice minister of health. And then in Iran, we have Ministry of Health and Medical Education, and the public health section is governed by a vice minister. He is public health vice minister. And again, we try to integrate this recommendation to national immunization strategy that is going on, and it is underway to be developed. And finally, we agreed on to reassess this process and these scenarios to update every 2 or 3 years. And finally, a full reprioritization exercise will be conducted every 5 years. And with that, I stop here, and I appreciate your patience and your attention, and I will be glad to take any question or receive any comments. Thank you very much. Back to you, Roman.
Thank you. Thank you so much for that, Akbar. And so we've had a really rich feedback from our countries, just in how they've actually applied the process, looked at the criteria, gone through the ranking, used those criteria to foster rich discussion among their NITAGs so that they can then refine the process towards implementation. We're going to start our Q&A session now, but I first just wanted to check if there were any questions in the chat. And I think possibly the first one seems to have come up just after Prof. Solomon's country experience. So I think I'm going to direct that at you, Prof. Solomon. It's a question from, and now I've lost the name.
Kolaole, and I think from Anthony. I think I
Yes.
see 2 questions actually, probably targeted toward us.
Perfect.
Yeah.
So let's start with those. Thank you.
Yeah. I think first I will read the questions. I think Kolaole has asked, why is the yellow fever vaccine not high priority for Ethiopia, seeing as it a global travel hub? I think this is an important question. We have only considered new vaccines for prioritization if they are not already introduced into the Ethiopian setting, or if there is no plan to introduce them in the near future to the API program in Ethiopia. Therefore, yellow fever was a part of the application, which has already been decided to be introduced in Ethiopia and part of the portfolio of application for the Gavi. Therefore, we didn't include yellow fever in this prioritization exercise because it's already being considered for possible introduction into the Ethiopian setting. That's the reason. Now, the second question is by Anthony, and yeah, it was a comment, first part. The question is, were there any major disagreements, and if so, how did you resolve them? Yeah, this is also a key question, an important one, and yes, there was some disagreements among the NITAG members on the, during the scoring exercise and so on. But before finalizing the scoring, we had discussion among NITAG members. They were allowed to reflect their views, and after reflecting on their views, we were returning back to the evidence. The evidence was presented again, discussions were conducted, and usually such disagreements were managed through consensus. Therefore, we haven't even voted on any disagreements. Rather, consensus was reached on every criteria. That's a good point, but there is always potential for disagreement, and there should be ways, how to address such disagreements. Yeah, I think I will read the other.
Sorry, Prof. Solomon, maybe it's also interesting to ask Prof. Akbar to weigh in on that question if they had any disagreements.
Yes, sure. I think Akbar, you can reflect on.
Yes. Thank you very much. And Joanna can help and can weigh in on this. The process, the tool, the strength of the tool is exactly this. They can balance, different ideas, and through the process of voting and through the process of listening to all evidence about all criteria, people finally can vote. And through the process of voting, finally, we can have the summary of NITAG members' idea. Totally. And so every disagreement after saturated discussion will be resolved by a voting process, and this will be the result of this. The result of this tool. This is my idea. Joanna may weigh in.
Yeah, thanks so much. I think, and there's also this question in the chat about, Minister of Health recommended or compelled to use this process. And as was just said, I think this was discussed at SAGE in March, and we can share as well the summary of the discussion. I think what really came through is the importance of having a country-led, evidence-informed process, a formalized process that enables to have a consensus on the recommendation, not individuals, but a consensus. And that, in a way, protects the decisions and the recommendations that are being made, and really allows the minister to defend this choice, whether it's a question of potentially questions from manufacturers or questions from other external stakeholders, maybe some, vaccine-specific initiatives that may encourage a country to go for one vaccine or the other. This process is really about leveraging the available evidence to reach a consensus on what are the national priorities, and really putting the NITAG in the center of this process. And so SAGE recommended to use multi-criteria decision analysis, which is the fundamental methodology of the NVI-PST. So this recommendation, especially in the current context, and I will start a teaser for the next webinar where we will talk about optimization, I think is really essential. And ensuring that the decisions that are taken in a context where funding is unpredictable, reduced, the availability of evidence, and ensuring that those trade-off decisions are taken in a formalized process is really essential. So this guidance is part of the what is recommended, and that we strongly encourage, as per the SAGE recommendation, every country to engage their NITAGs in reviewing future priorities, as well as optimizing their current schedule and overall portfolio. And there will be another session on this topic at SAGE in March. So we will continue the conversations and we'll bring more perspective as well on the recommendation to countries and ministers of health.
Thank you for that, Joanna, and Akbar and Solomon. So just to clarify maybe the next question. So over the course of the series, because we seem to run out of time for questions, there are some questions that people ask for more clarity on. And we've been collecting those and trying to drop them in as part of our question and answer and discussion. So this one was posed from one of the attendees from session 3. And the question was about how could we further reduce the 71 criteria after prioritizing the vaccines. So I know that there's some points that we'd like to talk to about that, but I'll start off with Joanna, if you could respond, please, and then Akbar.
Yes, thank you so much, Ramonda. And I think it's a good question because it can feel quite overwhelming looking at the list of all the criteria. And, we presented that, you need to then collect the evidence, summarize the evidence around each of the criteria that are selected for every vaccines that are being considered. But this list of 71 criteria is really an indicative list, and it's to facilitate the work of the Secretariat or the NITAG working group. It's for each country to pick and choose, essentially. So adapt based on the vaccines that you're considering, based on your current context and your priorities, what you see as the most important criteria to consider when going through this prioritization exercise. Some may look at, I won't go through the whole detail, but you remember the slide that I showed with, and that was also showed by Professor Salomon on the scoring for each of the criteria. There are not 71 there, but maybe 12 to 15 on average is probably the number of criteria between the important one and the infeasibility one that are picked by countries. So this list is really, let's say, an overview of the main criteria that are usually used by countries to inform their decisions on new vaccine introduction. And it's up to you to choose from that list which one would be most relevant. And I'll let maybe Akbar add to this and share your experience on selecting the criteria.
Thank you. What I can add is that, those 71 criteria, they are very similar. I mean, you can see a lot of overlap among them, and they are not distinct. And so you can categorize them as they were categorized in terms of addressing the epidemiology of the disease or the cost of the vaccine or program scheduling, etc. So there are different categorization of those criteria. So usually it is not very difficult, and as we experienced, it is not difficult to reach to, for example, 15 or 14 criteria list. And the big issue is keeping a minimum balance between importance and feasibility, because with very low number of criteria in one of them, so there will be not enough variability among different vaccines, and you cannot discriminate vaccines. And in the final graph, if all vaccines are in a line, a horizontal line or in a vertical line, that means you cannot discriminate them from in terms of importance or in terms of feasibility. This is the important point that I can say. Thank you.
Great. I think I see hand from Adija. Adija, please continue.
Oh, thank you, Solomon. I hope you can hear me.
Yes, we can hear you.
Okay, first of all, it's great to see you. I think the last time we met was in Brazzaville a few weeks ago. So I'll just want to start by really saying congratulations to Ben and the team, the entire niche team for to keep us educated on the VPOP. And thanks, Joanna and Maya and colleagues. So mine was first of all to you, Prof. Solomon. Congratulations for publishing the process. I think it has made your presentation easier because we're able to read and share your article widely ahead of this webinar. So thank you for doing that. And I really appreciate that the two countries have RSV as a priority. To my understanding, Ethiopia has not prioritized RSV because the vaccines were not yet available. So do we plan to have a reprioritization process as Gavi is working towards informing countries of what will be available for RSV, and maybe with first country to introduce around 2027? That would be good to know. And for Professor Akbar, I would like to know for RSV, what has disqualified RSV in particular from the process? I think for Ethiopia it was clear, but from you, did not get it clearly. And secondly, there's also the new TB vaccines coming. So will Ethiopia go restart this process, I don't know, in the next 1 year, so that we can have all the evidence needed for the other vaccines that are in the pipeline? That would be good to know. And finally, I'm actually having this call from Ethiopia. I think Ethiopia is doing extremely well. We're on the field. We've witnessed the malaria vaccines introduction, the Hep B bird dose, which is effective. I was curious, why did the NITAG has put malaria on the list, the initial list of vaccine, given that the vaccine is already introduced before the prioritization? And finally, what are the advices that you can give to countries that have not started the process and that you think is important for them to have a successful prioritization process? Thank you, and back to you, Prof. Salman.
Adija, can you repeat the one which is the vaccine which is already introduced? Which vaccine are you referring to?
I saw on your first slide where you have the long list of vaccines, there was malaria vaccines. So I was wondering why the malaria vaccine was there, given that it's already introduced in Ethiopia. In one of your earlier slides, you went quickly through it before starting the prioritization. Yes.
Yeah, I think this is to start from, your last question. This is all the available vaccines were considered, even if they are introduced or not. They were listed out. Among those listed, if it is already introduced, we immediately drop it. And if it's not introduced, we have made some preliminary discussions and selected few for potential prioritization based on evidence. I think the other question you have is around RSV in Ethiopia, and I think it's RSV, respiratory syncytial virus, is a huge burden in the Ethiopian, setting, and which is becoming an obstacle for achieving sustainable development goals regarding infant and under 5 mortality. Therefore, we are keen to introduce it, but given that the current constraints around resources and availability of vaccines, as I said earlier, we haven't put it on top. But we have a plan, given things remain dynamic, and we have a plan in 2 years' time. Somewhere in the middle of, the national immunization strategy, probably if things are, evolving fast, to do another similar exercise to revisit the ones we have prioritized already. Therefore, this is not the end, and we will, given there are evolving issues or developments, we'll go back and look at, how we'll do reprioritization and probably do the appropriate recommendation for these vaccines. I think the other was forwarded to Akbar. I will
Yeah,
come on
yeah.
another issue, but I will give the floor to Akbar.
Yeah, I'm mindful of time. I know my should continue the session very quickly. The question was very great. My answer is that prioritization process means ignoring some options, excluding some options. During a 5-year period, Iran decided that we cannot introduce more than 4 vaccines. And out of 22, 23 primary list of vaccines, we shortlisted these 6 vaccines. Then we prioritized them. And among these 6 vaccines, we were convinced, for example, HPV is more important to be introduced in Iran than, for example, RSV. So that doesn't mean that RSV was not important for us in terms of the program constraint, money, etc. We have chosen those 4 out of those 6 shortlisted vaccines. Thank you. Over.
Great. Thank you very much. I think because of time constraint, we'll try to address, there was a question on TCV on the chat box, and I will give the floor back to Ramonde. Back to you, please. Thank you.
Thank you so much for that great discussion. And I think now just to hand over to Maya to close and sum it all up for us. Thank you so much, Maya.
Well, thank you very much, and thank Nish for organizing this and JSI for facilitating this. Thank to all the presenters. It's been really a rich presentation, and a lot of theoretical approaches have been also compared to the country experiences. This process is really a country-led, NITAG-led, supported by EPI. And I just want to really emphasize this, that we are switching our models that maybe in the past there have been individual influences on whether to introduce or not to introduce a vaccine. We are really trying to shift this to an evidence-based and vaccine and multi-criteria decision-making process that have been discussed. It's really meant to be evidence-based, and although we know it's a complex process, and we heard also many influences are to be considered. These may be from individual influencers in the country or outside the country. And it's really important that this process is properly followed so that these different influences have their place, but have a country-led voice and also can be weighed one against the other. I really love the slogan that was just, or the thing that, the phrase that you were just using. Prioritize means dropping something. And I think this is really an important understanding that we can do everything and we need to prioritize. And we need to prioritize based on criteria that are relevant for the country and for the setting and for the different communities in the country. I think it's also important to look at that broader population-based and community perspectives in this process. There may be sometimes some heated discussions, but I think what we also learned is that the discussions and the evidence that is collected and the discussions that follow are there to actually reach a consensus. And that is really important, that we listen to all the criteria, we listen to all the voices, and then present a consensus. In a case that a consensus cannot be reached, there may be always some nuances to to reflect, and we've seen examples that 2 scenarios then were presented to the leadership. I think the other part that I really want to also, that I took away, is that the recommendations are then discussed with the different officials in the Ministry of Health, and then later maybe with other ministries as well. I'm thinking of finance or other kind of important stakeholders, and that's really important, that this is discussed and agreed upon by the leadership of the ministry. Obviously, the integration in country plans is really important, in country plans for programmatic reasons, but also for budgeting purposes. That's really important that we think about how to present this in a sustainable way. We also have heard, maybe not today, but from other countries and decisions, that it's really important to make this decision process to some extent, maybe that depends also by country, to make it public. It may be of importance that the different communities are aware of how the different evidence criteria and the different reasons have been discussed by experts, and that this is the best available option. We've seen that sometimes it's actually very, very important. It also is important that the different stakeholders are included in the decisions in the NISAC. So if there is an HPV vaccine, that the Cancer Society and that the obstetricians are actually included in the discussions at some point. So these kind of things are obviously already in the NITAC. So, but if we then can publish this, that may be something that can be considered. So with that, I really want to thank everyone for their fantastic contributions. We also want you to, the organizers want me to remember you that please fill out the poll that was just shared, so that the organizers can improve every session, every time. I really want to thank you. Sorry for going a little over time. And back to Raymond. Thank you.